All right, today we're going to discuss Protocol 2. So we've gone over Protocol 1, which is predominantly a disk protocol. However, it can be used for acute non-disk disorders as well, because if there is a radicular component, regardless of the disorder, you will use Protocol 1. Or if you want to start slowly and gradually with a patient, you will use Protocol 1. And these are decisions you'll make when you have some clinical experience under your belt. Protocol 2 is for patients without a radicular component, whereas Protocol 1 is predominantly disc-oriented. Protocol 2 is used to reestablish physiologic ranges of movement. The preparatory procedures are identical in terms of preparing the table, the patient, and the doctor. The protocol changes. The recipe for this one is 10 2-second pumps in the physiologic ranges of flexion, right and left lateral flexion, right and left circumduction, and extension. And that pretty much covers all the anatomical ranges of movement for any functional spinal unit in the lumbar, thoracic, or cervical spine. And circumduction is a combination of flexion and lateral flexion. And because of the dynamics of the lumbar spine, it brings in rotation to the equation as well. All of these, except for extension, are done with the vertebrae preloaded or at the point of the barrier of elastic resistance. With Protocol 1, we tend to do one segment. Occasionally, we might do multiples, but generally with Protocol 1, we do one vertebral level. With Protocol 2, you have the option of doing one vertebral level or multiple vertebral levels. It's a wonderful mobilizing technique for one vertebrae or for a group of vertebrae. So in an elderly individual where there's a lot of dysfunction, a lot of fixation, restriction in multiple ranges of movement, advanced degenerative disc disease, facet arthrosis, you can actually mobilize numerous segments, and they love it. And you'll enjoy it too, even without any symptoms. It's a great preventative procedure to just take the spine through all of its natural ranges of movement. And this is just the general recipe for flexion. You'll get more out of the video than out of these next few slides, but this will give you kind of a general guideline to follow for flexion. Here's the guideline for lateral flexion. Here's the guidelines for circumduction. And here's the guidelines for extension. There's no contraindications to extension if you're using Protocol 2, because if there was a disc issue, it is considerably healed, so the patient is able to assume an extension position. And extension is an extremely important movement to reestablish, and is often, in terms of the realm of fixation, it's often the first fixation to occur at a functional spinal unit. Because we are flexion beings, almost everything we do puts us into a flexion position. sitting at your computer or sitting eating lunch. Just two of numerous examples that put us into a forward flexed posture. All right, the big caveat for extension. It is the one maneuver where we reverse the line of drive. Everything else is 2/3 I to S, 1/3 P to A. But for extension, you're going to flip that, and it'll be 2/3 P to A and 1/3 I to S. And of course, that's going to enable you to establish extension movement through the use of the caudal section of the Cox table. And again, that'll become much more apparent when you watch the video on Protocol 2, which is part of this week's content. All right, some hints on hairy backs, and they're out there. It's challenging enough without hair to get a decent contact on the spine, and hair tends to be soft and you tend to slide on it. So we actually ask the patient to have their significant other shave the back in the area that we're going to be working. And in this particular patient, they actually did that for us. You'll notice there's a line of demarcation right over here. Well, prior to his wife shaving him, the whole back looked like that. And it was really difficult to get a contact and maintain it. But the other element is it can be very painful for the patient because the hair can get pulled, and you can actually get more pain from the patient than you would from the procedure. So you definitely need to do that with gentlemen like this. All right, there's another reason. The sticky EMS pads. They don't like hair, and hair doesn't like them. And of course, we use the disposable variety, and it's got a tacky, sticky element to it that forms a nice adhesion to the skin if there is no hair. If there is hair, it does not make good contact, and of course, that's going to have a negative impact on the effectiveness of the therapy. And then trying to get them off, oh boy, that is challenging because you're going to be pulling some hair with it. So I think you get the point. Some people will need to have their backs shaved. All right, one more point or tip to help you with slippery backs. Two options. I use the first every day. Nitrile gloves. Don't get latex. Some people are allergic to them. But a nitrile glove forms an excellent grip to the patient's spine and will prevent sliding. You'll feel a lot more secure with that glove on. Number two, if you don't want to use gloves, if you have some hand sanitizer in your room, if you'll take a little dollop of it and just kind of spread it around the patient's lumbar spine, as it begins to dry, it creates kind of a natural tackiness where you can get a grip. But I think once you try the gloves, you'll want to have a box of these in the room, particularly when you get someone with really soft, dry skin where you just kind of slide on it. Alrighty, well, there's a few tips and some good general information for you.